اتفضل دكتور هاني.
بسم الله الرحمن الرحيم. These are the objectives of my talk. Hepatitis B virus is one of the most challenging and debatable topics in clinical hepatology. A great part of the problem is related to the complex life cycle and immunopathogenesis of the disease. For 20 years, we have been proud of achieving undetectable hepatitis B DNA. But if we stop therapy, the virus relapses in the majority of cases. So, have we truly cured the virus? The answer is no. Suppression is not cure. It is affecting more than 250 million individuals all over the world. It is the leading cause of HCC, accounting for about 56% of the cases, with the mortality of about 1 million individuals per year. This means that about 2 patients are dying every minute from the complications of hepatitis B. The prevalence of Egypt is estimated to be between 0.8 to 1%, according to the latest WHO and Ministry of Health reports, 2022. The prevalence is much lower than before, but still a prominent public health issue. And again, Egypt is receiving expatriates from different countries in the world, not only expatriates, students and workers from countries in which hepatitis B prevalence remains high. In addition, with the increasing use of biologic therapy, chemotherapy, and immunotherapy, the risk of viral reactivation in Egypt is going to increase. 2,000-year-old human hepatitis B virus genome was successfully reconstructed in an Egyptian mummy by epigenetic and DNA studies. This has been published 6 years ago. But what is more alarming is that only 13% of the patients know that they have the virus, and only 2.6% are receiving treatment. We are looking for the future. So we have 3 different definitions. The current goal we are using now for our patient, majority of us are using, this is defined, what is called the partial cure, which is defined as sustained viral DNA suppression, but still there is positive hepatitis B surface antigen. If we talk about functional cure, this is defined as sustained surface antigen loss with undetectable hepatitis B DNA for at least 24 weeks after end of therapy, with or without surface antibody seroconversion. Functional cure is considered by all international guidelines as the optimum therapeutic endpoint. We have to remember also that hepatitis B, unlike hepatitis C, has a reservoir of cccDNA, integrated DNA inside the nucleus of the hepatocyte. So we aim at complete cure, or what's called the sterilizing cure. This means eradication of all traces of the virus, including cccDNA and integrated DNA. This is a high bar, which is not in focus right now. In order to talk about the common novel medications, we have to know the current status. We have now 3 excellent drugs: entecavir, tenofovir fumarate, tenofovir alfenamide, with interferon, which is rarely used nowadays. These 3 oral medications are considered by international guidelines as having high degree of safety, tolerability, and the most important, very low risk of resistance, as seen in this slide. International guidelines also state that functional cure has importance regarding decreasing the progress of liver cirrhosis, decreasing progress to decompensation and mortality. But what is more important is its effect on the incidence of HCC. This is a landmark study on more than 20,000 patients in Hong Kong. These patients had chronic hepatitis B. They were on nucleotide analogs, and they have been followed up for 8 years. What is apparent here is patients with surface antigen clearance are associated with much lower incidence of HCC compared to those with DNA suppression only. As you see here, 0.6% compared to 5.6%. Also, what was very apparent in this study is that out of this huge number of patients, only 2.1% got surface antigen seroclearance after a median follow-up of 5 years. And this has been also confirmed by other studies as seen in this table. You see the annual clearance rate for after nucleotide analogs is about 1% or less. However, pig interferon clearance rate after large meta-analysis of about 14 studies is slightly higher, about 3 to 7%, but interferon usually given selected group of patients. And for example, with low surface antigen with genotype A, which is now very few along the globe. However, or unfortunately, nucleotide analog therapy withdrawal is associated with up to 90% virological relapse within 1 year and possibility of 5 to 10% of severe flares. So why do we need functional cure? To avoid lifelong therapy, to avoid risks of hepatitis flare, to improve clinical outcome, to reduce the costs, to reduce the risk of reactivation, particularly after chemotherapy. And what is more important is to reduce the stigmatization in work, marriage, etc. If we are going to talk about the new novel medications, we have to throw a light on the life cycle of hepatitis B virus, which is very complex, unlike hepatitis C, which is more or less straightforward. Here, the virus will enter the hepatocytes through certain receptors called NTC receptors, or sodium taurocholate receptors. After entering, it will release its coat and then enter the nucleus. Releases what's called relaxed circular DNA, which is going to be transformed into complete circular DNA. And this is a mini chromosome, and part of it is going to be integrated in the hepatocyte and the genome, and this is called integrated DNA. These are the troublemakers, the cccDNA, integrated DNA. Then cccDNA is going to be transcribed to pregenomic RNA and messenger RNA. Messenger RNA is going to, in the cytoplasm, be translated into proteins, mainly surface antigen, core antigen, and polymerase. Polymerase is going with the pregenomic RNA to be packaged inside the nucleocapsid, and then inside the nucleocapsid, RNA is going to be retranscribed to DNA by reverse transcription. This is the site of the nucleotide analog therapy you have in hand now. Then the mature capsid either is going to be covered by envelope of surface antigen released or recycled to the nucleus to replenish the store of cccDNA and integrated DNA. A key point of the virus is the production of tremendous amounts of hepatitis B surface antigen subviral particles. These, in millions and trillions, they act on immune system, leading to immune exhaustion and immune tolerance. This one important causes chronicity. So other barriers for this, in addition to that, a huge number of particles and the immune exhaustion, is the presence of integrated DNA and cccDNA. From the host side, the immune system includes adaptive and innate immunity. The innate immunity, you have the macrophages and dendritic cells, where there are toll-like receptor, they are part of leading secretion of interferon cytokines. We have T cells, particularly CD8 T cell, CD4, and B cells also participate. A huge number of hepatitis B surface is affecting this immune system. So if we are going to speak about the target sites for these new novel medications, we have the enter inhibitors, like that inhibit entry of the virus, like bulevirtide. I think Dr. Hisham is going to speak about this. We have the drugs that cut or edit the cccDNA, integrated DNA, this gene therapy, and another strategy by silencing this without cutting, and as if you are cutting the virus from the roots. And we have the RNA interference drugs mainly small interference RNA and antisense oligonucleotide or ASO. By different mechanisms, they degrade the RNA. We have the capsid assembly modulators or CAMs. And we have reverse transcriptase inhibitors and the drugs we have in hand nowadays. And also, finally, we have the secretory inhibitors, nucleic acid polymers that inhibit the secretion. From the immune side, we have the toll-like receptor agonists. We have fantastic therapeutic vaccines affecting or targeting the T and B cells. And we have engineered monoclonal antibodies that affect the surface antigen. And we have the checkpoint inhibitors. So for the time being, we have more than 50 drugs in the pipeline. And the majority in the first in the grades of development, like phase 2, 2B, something like this. These drugs can be categorized in these groups, 3 groups: replication inhibitors, antigen-reducing drugs, and immune modulators. The hope was great, but the outcome was disappointing. This is an important systematic review and meta-analysis just published very recently. The outcome of monotherapy with or without nucleotide analogs was around 0%, with the only drug was called piperoversen, which is an antisense oligonucleotide. I will talk about this in the coming slides. So research now is shifting towards combination therapy in a form of mix and match approach. I will share you some of the slides for the outcome of some of these novel drug therapies. Here, an important study published in New England Journal just a few years ago regarding the efficacy and safety of piperoversen. It is not only antisense oligonucleotide, but also have an immunoregulatory stimulatory effect, toll-like receptor 8 agonist. An important study, B-Clear study, published regarding piperoversen in the high-dose arm of 300 milligrams subcutaneously every week for 24 weeks, succeeded in achieving functional cure rate in patients with and without nucleotide analogs in the range of 9 to 10%, as seen in these squares. The result was not outstanding, but much better than what has been published before. And the researchers struggled for many years, and this is the right way for the outcome. Regarding combination study trials, here 2 slides summarize the majority of the novel trials. 24 weeks after withdrawal of therapy, the outcome ranges from 10 to 30% as seen in the pink columns. Few studies commented on the sustainability of these results, and they found about 5 to 25% that say function cure, and as seen in green. But what was interesting, this slide or these results, is that patients with surface antigen below 1,000 units have much better results, reaching up to 40 or 45%. These combinations therapies face several challenges regarding safety, durability, drug resistance, cost effectiveness, and proper drug combination. In addition to quantitative surface antigen, now there are emerging novel biomarkers to predict the response and to predict the relapse. This is serum hepatitis B correlated antigen and serum hepatitis B RNA are developing. And so future therapy will be biomarker guided. An important question comes in mind. Can we achieve functional cure with current therapy? There are 2 strategies studied: nucleotide analog withdrawal in E antigen negative chronic hepatitis patients and pig interferon add or switch to therapy. Regarding the withdrawal nucleotide analogs, there are variable results, but this is an important study called STOP NOC study. Patients were receiving nucleotide analogs for more than 4 weeks and stopped for 96 weeks. The stop arm achieved 10% surface antigen loss, but the continue arm 0%. However, the recent guidelines of EASL do not recommend stopping except in certain category of patients, those without cirrhosis, without chemotherapy, and without comorbidities, with sustained DNA undetectability for more than 3 years, and those with very low surface antigen. And they should be under very close observation because the flare is catastrophe and sometimes may lead to decompensation and liver transplantation. However, American study recently also, they do not recommend withdrawal. Just I have 1 minute only. Do not recommend nucleotide analog withdrawal, very restricting this point. The second strategy is pig interferon add or switch to therapy. The result varies from 7 to 14%, and with the add-on much preferred compared to switch to because of lower incidence of relapse. However, the results of this combination are very heterogeneous and not yet included clearly in guidelines. So we are looking for the future. We are looking for future better results with the novel therapies to achieve WHO 2030 aim for reducing hepatitis incidence by 90%, reducing mortality to less than by 65%. And this is the end of my talk. This is the conclusion. We are no longer limited to viral suppression. We are entering the era of curative strategies. The next wave of therapies for chronic hepatitis B is rapidly evolving. Functional cure is the optimal endpoint, but remains infrequent with monotherapy, except with bepirovirsen. Outcome with multi-target drug combination approaches are encouraging. The field is shifting toward precision medicine, integrating surface antigen levels, hepatitis B core-related antigen, hepatitis B RNA to guide individualized therapy. The challenge now is selecting the right patient, the right strategy, the right time to achieve a durable cure. Thank you.